Hello, welcome everyone. Zooming through ID. I'm Dr. Gopal. I'm one of the infectious disease specialists in the South Florida area. I trained at Duke University and I've been practicing for a little over 20 years now. Um, I am here at the Broward North facility. I'm the medical director for infection control here, and I do chair the antibiotic stewardship. Zooming through ID is an opportunity I have created to nurture intellectual curiosity among the residents. When internal medicine residents rotate with me, they either pick a topic of interest or I help them find a topic and they do a little project, they do some research and then talk about what they discovered. And that is this session, the Zooming Through ID. We have today, Peter is going to talk about antibiotics. Peter rounded with me and he was excellent. I caught him shining one day. I went into a room, a patient room, and then it was a follow-up patient, but I saw him that he was using the language line and getting a very thorough history. And then he's very good in presentation and very great bedside manners. And he is going to talk about antibiotics. So, Peter, you can introduce yourself and yeah.
Thank you, Dr. Gopal. So, as Dr. Gopal said, my name is Peter. Originally from California, matched here at Broward North for internal medicine. And then I had the pleasure of working with Dr. Gopal early in my residency. So knew a lot less back then, but I learned a lot from her and a lot from the rotation. And one of the reasons why I wanted to do antibiotics is because as an internal medicine resident, a lot of times, on wards, we're starting patients with just broad spectrum antibiotics. And very quickly, we start changing antibiotics, sometimes just as quickly as the next day. And it was for me, I wanted to kind of like have a clear and concise, like, methodology in my head, what the mechanisms are, what the coverage is for antibiotics. And that's kind of why I chose to do antibiotics for this presentation.
Yeah, you can start sharing. Yeah, that is this antibiotic is very important for infectious diseases, and this is awesome. You're putting this together. So,
Okay. I'm going to go ahead and start sharing.
okay.
Okay. And Dr. Gopal, can you just confirm you can see my
Yes,
screen?
yes, it's
Okay.
perfect. I can see it. Okay.
All right. Perfect. Okay. So we're going to start with our beta-lactam antibiotics. Again, we're going to cover mechanism of actions and the bacteria that is typically covered by our antibiotics. So first off, with our beta-lactams, we're going to start with our penicillins. So mechanism of action here is that penicillins will inhibit your bacterial transpeptidase, and this is typically found, it's an enzyme that's used by bacteria to build cell wall. So they block that bacterial transpeptidase, as you can see in this previous picture here. You can see that the beta-lactam antibiotics, they inhibit transpeptidase, and therefore they block the bacteria from building their cell wall and leading to cell death. So first we'll start with our anti-staphylococcal penicillins. These are going to be our dicloxacillin, nafcillin, and oxacillin. You're going to have great gram-positive coverage. They do contain a side chain that protects from staph beta-lactamase, and they are coverage against MSSA. So these will be commonly used. You'll see them being used a lot for infections such as impetigo and cellulitis. Next, we have our penicillin G and penicillin VK. So these are actually inactivated by our bacterial beta-lactamase, and that is typically found in gram-negative bacteria and also gram-positive Staph aureus. Clinical uses for these two, you'll see them being used intrapartum prophylaxis against group B strep. They're also used for group A strep pharyngitis. And you'll see these used again for prophylactically against pneumococcal infections in patients with sickle cell disease. Next, we have our aminopenicillins. These are going to be our ampicillin and amoxicillin. So for these two, these are going to have gram-negative coverage, especially against Haemophilus influenza. They do have some gram-positive bacteria. They do not cover MRSA. They are degraded by beta-lactamase, and you'll commonly see these being used, especially our amoxicillin for otitis media, which is typically caused by strep pneumo and non-typable Haemophilus influenza. Next, we're going to talk about beta-lactamase inhibitors. So we have Zosyn, Unison, and Augmentin. So Zosyn is going to be our piperacillin combined with a beta-lactamase inhibitor, tazobactam. Unison will be ampicillin combined with sulbactam. And Augmentin is amoxicillin combined with clavulanic acid, which is the beta-lactamase inhibitor. So these are going to inhibit our bacterial beta-lactamase. Therefore, these are going to be are broad spectrum antibiotics. They're going to cover gram-positive bacteria and also gram-negative bacteria. However, for these three, for Zosyn, Unison, and Augmentin, they are not effective against MRSA or Pseudomonas.
The Sosin, there's a Sosin will be effective against Pseudomonas.
Sorry, that is
Amoxicillin and yeah, definitely
sorry, that is correct. Thank you for catching that, Dr. Gopal.
yeah.
Zosyn actually does cover Pseudomonas. That is an error on my part, but Zosyn does cover against Pseudomonas. So again, so Zosyn here, it does have anti-pseudomonal coverage, and you will have some increased gram-negative coverage here. So one of the things that reactions that you can get with the use of penicillins is something called Yarge-Hexermeyer reaction. And this is typically when penicillin is used to treat syphilis, which is a spirochete. You can often develop flushing, fever, and chills. This will typically start within several hours after administration of penicillin. And this is typically characterized by an immune response due to bacterial cell death. The treatment for this is really supportive care, and it will typically resolve within 2 days.
Just a comment about this Jarisch hexamer reaction. We do see that, like Peter was saying, with syphilis patients, but for pregnant patients coming in with syphilis, penicillin is the drug of choice. So, we will do not hold penicillin treatment for for pregnant patients on syphilis, thinking about whether anything happens, this Jarisch eczema reaction. But if they get this reaction, supportive care, Tylenol, everything is good. But definitely for pregnant patients, we have to desensitize them and use penicillin for syphilis. Yes.
Yes,
Mhm.
thank you, Dr. Gopal. Next, we'll move on to our cephalosporins. So again, these antibiotics will inhibit our bacterial transpeptidase. Again, it's an enzyme that's used by bacteria to build their cell wall. So they inhibit that enzyme, and therefore you have the autolysis of bacteria, and you have the bacterial cell wall breakdown. So our cephalosporins, they are composed of 5 generations. They do cover gram-positive organisms. And as you increase in subsequent generations, you will begin to increase in your gram-negative coverage. So first generation will be our cephalexin, which is our Keflex, and cefazolin, which is Ancef. So these will be gram-positive coverage, including MSSA. They do not cover MRSA. And you'll often see this, especially with Ancef, you'll see this being used in the OR a lot preoperatively for prophylactically against skin infections. Our second generation cephalosporins, these are going to be our cefaclor, cefoxitin, cefuroxime, and cefotetan. These are going to have increased gram-negative coverage compared to our first generation. So you'll have coverage against our E. coli, Klebsiella, Neisseria gonorrhea, Proteus, Haemophilus, and they do also have increased anaerobic coverage. Our third generation cephalosporins, these are going to be our ceftriaxone, which is our rocephin, ceftazidime, cefotaxime. These will have, again, increased gram-negative coverage. They do have less gram-positive coverage. Ceftriaxone, you will see this being used in meningitis, and ceftazidime does cover Pseudomonas. Our next, we'll go into ceftazidime, avibactam. So we just discussed the ceftazidime. Here, Avicaz is combined with avibactam, which is a beta-lactamase inhibitor. You do have coverage against ESBL and carbapenem-resistant bacteria. Our fourth generation cephalosporin, we have cefepime. And again, going up in generation, we do see the increased gram-negative coverage. And here, cefepime does include coverage against Pseudomonas. Our fifth generation, we have ceftaroline, and ceftaroline covers MRSA. We also have a combination called Zerbaxa. This is going to be our ceftaroline combined with tazobactam, which is a beta-lactamase inhibitor. Here, we're going to have gram-negative bacteria with ESBL bacteria and pseudomonal coverage.
The it's cef it's actually the Zerbaxa is ceftolozane and tazobactam, not ceftaroline.
Oh, okay.
Yeah,
Sorry
yeah,
about that.
ceftolozane. Yeah, so it is a different cephalosporin, ceftolozane, and
Uh-huh.
tazobactam. So this is a very extended
Oh,
spectrum. Yeah. Mhm.
that's correct. Sorry, Dr. Gopal. That should have been ceftolozane tazobactam.
Okay.
For our next, we'll move into the carbapenems. So for carbapenems, we're going to have meropenem, doripenem, ertapenem, and imipenem. These are going to inhibit bacterial transpeptidase, which is an enzyme, again, used by bacteria to build their cell wall. Uh, Carbapenems are going to be effective against ESBL producing bacteria. These are which are typically found in our gram-negative bacteria, and they are effective against Enterobacter. So ertapenem, great thing about ertapenem is it's typically given once daily. It does have weaker activity against Pseudomonas.
We don't use invents at all for Pseudomonas. So
Yep.
it's basically we treat as if it is Pseudomonas infection, I never use ertapenem. Yeah.
Mhm.
Uh-huh.
And we also have imipenem, which is metabolized by the kidneys by dihydropeptidase, which does produce nephrotoxic metabolites. So it's combined with cystatin, which is a dihydropeptidase inhibitor. Next, we have linezolid, which is also known as Zyvox. This is going to block protein synthesis at the 50S ribosomal subunit. Here, it does cover MRSA and VRE. Now, some of the adverse effects of linezolid, which are pretty high yield, is it does cause serotonin syndrome. So it's used in caution with patients on SSRIs and MAO inhibitors. It can cause myelosuppression and also peripheral and optic neuropathy. Next, we'll move into the tetracyclines. So we have doxycycline, tetracycline. They inhibit protein synthesis at the 30S ribosomal subunit. They are effective against a number of atypical pathogens such as chlamydia, rickettsia, borrelia, brucella. Some of the adverse effects of our tetracyclines are photosensitivity. They do cause rash and blisters. They also have GI side effects such as nausea, vomiting, and epigastric pain. Next, we'll move into our macrolides. So here we're talking about our erythromycin, azithromycin, and clarithromycin. So these inhibit protein synthesis at the 50S ribosomal subunit. They are effective against intracellular pathogens. They are effective against respiratory pathogens such as strep pneumo, Haemophilus, and Legionella. Azithromycin is used for chlamydia. Other uses where you'll see macrolides being used are in pertussis. Some of the adverse effects of macrolides are going to be motility issues or GI motility, such as it can cause nausea, diarrhea, abdominal pain. It can cause infantile pyloric stenosis, so it's typically avoided in newborns. It does cause QT prolongation, so that's one of the things we have to look out for when using macrolides in our patients. It can cause cholecystatic hepatitis, rash, eosinophilia, and they also do cause P450 enzyme inhibition. Next, we'll move into our aminoglycosides. So here we're talking about tobramycin, amikacin, and gentamicin. And these are going to inhibit protein synthesis at the 30S ribosomal subunit. Uh, they are used clinically against aerobic gram-negative bacteria. They are not effective against anaerobes or intracellular pathogens. Some of the adverse effects of aminoglycosides, which are also pretty high yield, are going to be ototoxicity. So they are toxic to cranial nerve 8, which is our vestibulocochlear nerve. And this can result in ototoxicity and difficulty with balance. They're nephrotoxic, and you see increased risk with gentamicin. So when patients are on aminoglycosides, we are constantly monitoring their kidney function. They can also cause neuromuscular blockage. So they can block the release of acetylcholine at the neuromuscular junction. And so they're used in caution in patients with myasthenia gravis. Next, we'll move into clindamycin. So clindamycin inhibits bacterial protein synthesis at the 50S ribosomal subunit. They're used against anaerobes, such as Clostridium perfringens, Prevotella, Fusobacterium. You'll see clindamycin being used in aspiration pneumonia. And clindamycin is known for, has an increased risk of causing C. diff. For our fluoroquinolones, so they inhibit topoisomerase 4 and DNA gyrase. These are needed for bacterial DNA synthesis. For coverage, they are going to cover our gram-positive bacteria, gram-negative, and atypicals. And you'll see these being used a lot for UTI and pneumonia. So one of our fluoroquinolones, our ciprofloxacin, it does cover Pseudomonas. It does have great gram-negative coverage. It's used for GI infections, coverage against Klebsiella, Enterobacter, used in UTIs. And it does come as a eardrop, which could be used for otitis externa. Now, our adverse effects of fluoroquinolones, um, they do cause tendinopathy. They are pregnancy category C. They can be toxic to the developing cartilage, and they do cause QT prolongation as well. Next up is vancomycin. So vancomycin inhibits cell wall synthesis by inhibiting D-alanine, and that will prevent cross-linking, resulting in bacterial cell wall breakdown and cell death. And with vancomycin, we're going to have gram-positive coverage only, including MRSA, and it is used orally for C. diff. Now, some of the adverse effects of vancomycin, it's known for being nephrotoxic, ototoxic. You can get something called red man syndrome, and this is typically due to direct activation of mast cells, and it results in histamine release, and patients can be seen having flushing, erythema, and itching. And typically, if a patient does develop this, we do give them some IV Benadryl. We can slow the rate of infusion of vancomycin, but it is not considered a true allergy of vancomycin. Next is going to be metronidazole. So metronidazole causes DNA breakage and destabilization, which results in bacterial cell death. You have anaerobic coverage, and so it's typically known as being used for infections, quote unquote, below the diaphragm. And you'll see this clinically being used against anaerobic protozoa such as Giardia, Trichomonas, bacterial vaginosis. You have Gardnerella vaginalis and H. pylori. Some of the adverse effects of metronidazole, it can cause metallic taste and disulfiram-like reactions. And so patients that are on metronidazole are told to abstain from any alcohol while on metronidazole and for several days after they complete the course of antibiotics. Next up, we have Bactrim. So Bactrim is a combination of sulfamethoxazole and trimethoprim. So our sulfamethoxazole is going to inhibit dihydropteroate synthase, which inhibits the formation of dihydropteroate. And trimethoprim inhibits our dihydrofolate reductase, inhibiting the formation of tetrahydrofolate, which is our active form of folate. So again, our sulfonamides are going to inhibit dihydropteroate synthase. Our trimethoprim will inhibit dihydrofolate reductase. And so the combination of the two together will block the formation of tetrahydrofolate, which is our active form of folate. And clinically, we'll see Bactrim being used against gram-positive bacteria. It does cover MRSA. Um, Gram-negative bacteria, there is no coverage against Pseudomonas, though. It's used for PCP and also used for uncomplicated UTIs.
And just to add a little bit about Bactrim unique uses, Stenotrophomonas is where Bactrim is the drug of choice, and otherwise we have to use Livaquin. And then Listeria, Bactrim is an alternative. If somebody is allergic to penicillin, we use that. And then there are other opportunistic infection, Cyclospora, Isospora, those, also we use Bactrim. And Toxoplasma is another where we have to use. And the usual, gram negatives. Yeah. Okay,
Mhm.
great.
Thank you, Dr. Gopal. And adverse effects of Bactrim. So for sulfonamides, it does cause TEN, our toxic epidermal necrolysis. It can cause Stevens-Johnson syndrome. For trimethoprim, it can cause myelosuppression and also hyperkalemia due to blocking our sodium ENaC channels.
And Nocardia is another one for the Bactrim. Yeah.
Yes. And those are my references.
Oh, okay. Great. Great job. Wonderful. I hope you learned, and this is something we use every day. So,
Yes, thank you, Dr. Gopal.
okay.